The issue of kind of endocrine therapy and HER2-positive therapy, and how do we overcome resistance to those treatments. I think one of the things we touched on in a big way was, when patients develop resistance, particularly in the metastatic setting to endocrine therapy, how do we move forward and kind of make those cells sensitive again without having to go forward to chemotherapy. And CDK4/6 inhibitors and everolimus are the two main approved drugs in that setting, which we talked about, things like palbociclib, abemaciclib, ribociclib in the CDK4/6 inhibitor space, and then everolimus being the main mTOR inhibitor on the market. So looking at adding those to endocrine therapy and metastatic disease. And then we talked about a few of the clinical trials looking at high-risk stage 2 and stage 3 breast cancer, where the trials now are looking at adding a year or two of everolimus or CDK4/6 inhibition in addition to adjuvant therapy, thinking that that may produce longer disease-free survival and maybe even cure more women of their disease. So brain metastases are a huge issue, especially in HER2-positive patients where, as Dr. Carey was discussing, the disease tends to kind of have tropism for brain. And I think with HER2, we've got TDM1 now, we've got Herceptin, Perjeta, we've got capecitabine, lapatinib, and other agents on the market, making systemic disease control actually something we can often achieve for a long time. But where we come up with problems is in these patients who have systemic disease control but then develop brain metastases that are hard to treat. And I think one of the things that came up in the discussion after the talks was, how do you manage that? Huge question. I think radiation and stereotactic radiosurgery and sometimes neurosurgery are some of the biggest things that we use, just because those are the things for which there's the most data. There are clinical trials now, and then some people off study using intrathecal Herceptin. And I know there's a study at Duke looking at intrathecal Herceptin and pertuzumab. I'm not sure where that study is now in terms of if it's closed or still open. And then there's some new agents that we are hoping will prove useful in that space, like neratinib, which is being studied along with capecitabine for brain mets, and tucatinib, which has also received some fast-track designation from the FDA in that space. I find that to be one of the most interesting and sometimes most challenging types of breast cancer to treat, because even in the triple-positive space, there's so much heterogeneity. Some patients who have high-grade HER2 strongly positive disease may benefit very much from chemotherapy and anti-HER2 targeted therapy, and then continuing that therapy down the line. There are others potentially with more indolent disease where the ER is more of a driver that could potentially do okay for a while with endocrine targeted and HER2 targeted therapy and may not need as much chemo. So I think that's one of the types of breast cancer where the treatment truly is an art, and there are a lot of great options. In the United States, standard first line for HER2 positive metastatic disease is still a taxane with trastuzumab and pertuzumab. But I think there are a lot of ways to go and kind of ways to talk with patients about potentially even de-escalating that, because with metastatic disease it's kind of a marathon, not a race, and you want to pace yourself.